Do these medicines have to be taken lifelong?
Like diabetes, like hypertension, obesity is a permanent disorder.
What is the history about these medicines?
All these drugs have been slowly, taken off the market because of side effects.
How should patients, approach lifestyle change?
Mainly, the kind of lifestyle change that we are looking at should start in childhood.
How do we address this not so simple issue?
No, I think it's not a simple issue at all.
So BMI or body composition analysis?
Body composition analysis is a better tool than BMI.
Lifestyle or medication, what's more important?
Lifestyle is more important from the childhood.
One thing people should stop doing today. Few topics have broken the internet, like weight loss medicines. Obesity today is widely discussed, but it is also most misunderstood. Today, World Health Organization recognizes obesity as a chronic disease, and that has brought a dramatic shift in the way we treat it. Enter GLP-1 medicines, and that has moved weight management from frustration to possibility and blame to biology. At times, biology also needs a helping hand. But with buzz comes a lot of confusion. Are these medicines a shortcut, a solution, or just the latest social media trend? In today's podcast, we unravel all the questions that you may have about obesity and GLP-1 medicines. This is a patient-centered, science-first, non-judgmental discussion on obesity and GLP-1 medicines. So let's get started. I am Dr. Shruti Prabhu, Head Medical Services, Narayana Health, and with me I have two esteemed doctors who have been using these medicines and helping patients take control of their health. Welcome Dr. Subramanian Kannan. He is the Director of Endocrinology at Narayana Health and a clinician who believes in multidisciplinary care for his patients. Welcome Dr. Vinod, who is our physician and diabetologist at Manipal County Clinic, Narayana Health. Welcome both of you and thank you so much for joining in this discussion. Most people believe weight loss is about eating less and moving more. But why is it not that simple?
Yeah, eating less, moving more gives results for you. That's good. If it's not giving results for you and not able to lose weight, there is something called as metabolism playing a bigger role behind this. When you're trying to achieve a calorie deficit, metabolism changes. It tries to accrue more fat, hold on to that fat tissue. That is where the hormones come into play and does all these things. And GLP-1s work, counter to that and thereby giving better results than before.
So how do we address this not so simple issue?
No, I think it's not a simple issue at all. I think that is important to understand that obesity is a very, a heterogeneous or a complex subject matter. It starts with genetics. So if you have somebody who are predisposed to gain weight, you will gain weight. And that we see when you take a detailed family history, you will note that there's been a lot of family members who have crossed the 100 kilogram mark. And when I see that family history with the maternal side or the paternal side, the first generation, second generation, having a lot of obese members, then I clearly know that there is a genetic background playing in this. So that's number one. Number two is obviously the environmental factors in which the person is growing around. When there is a lot of abundance of food, when there's a lot of access to easy calories in a quick way, and that's the time when things start developing insulin resistance. And when you develop insulin resistance, you have a very high insulin circulating in your body. And when insulin circulates high in the body, no matter how much you cut down your calorie intake, that calories will convert it to fat. The third aspect, I think women particularly will appreciate this, is when they go into the perimenopausal window. So when they are going into the perimenopausal window, their metabolic rate slows down. And as Vinod rightly said, you try to put an effort to lose weight, your body will try to oppose it because it's a set point derived mechanism. So all these make obesity a very difficult, heterogeneous and a complex problem. And when we're trying to find a solution which is going to address only one aspect of it, which is calorie, you are bound to fail. And that's why I think a multimodal approach is very important.
Sure. So how do I know what is my ideal weight? And when doctors are prescribing the line of treatment, how do they decide what is the goal weight or target weight for a particular individual?
See, Indians are predisposed genetically for development of heart disease compared to other races like Hispanics, Japanese, or any other race. So, because of our own, genetic problems. Okay, so it's important to achieve a BMI of 23 for majority of the population at large. If you want to know what your BMI, weight by height square, so you can just Google it. You just need to measure your height and weight, and if you target a BMI of 23, then that would be the right weight you try to achieve. And there are even advanced metrics like body composition analysis or DEXA scan, or even simple metrics like measuring your waistline is also an important tool. So all these metrics will give you a better understanding what weight you should be. And, for the general population, if you want to make everybody aware about their right weight, BMI 23 would do well for Indians. For the Western counterparts, BMI is 25. So just to account for the lesser cardiovascular risk they have, BMI target is less for the other races. For Indians, BMI of 23 is highly recommended.
So I think that is an important issue because we keep taking the BMI ranges of the broader global average, but for I think Asians and Indians it is lesser, and that is not really known much. So you have anything to add about?
What is the right weight for you is a question that patients have a lot of expectations when they come to the clinic. They want to get into their old jeans, they want to fit into their college clothes, but we also have to be realistic about it. BMI of less than 23 is great, but it may not be achievable in everybody. So what I tell patients is, what is your comorbid illness that we're trying to address along with obesity? If it's obesity with, say, PCOS, or polycystic ovarian syndrome, a 5% weight loss will help you regulate your cycles better. If you have obesity with diabetes and hypertension, a 10% weight loss will help you get these conditions under good control with the requirements of medications being much less. If you have cardiovascular disease and heart disease, you want about 15% of weight loss. If you have fatty liver disease, about 10% of weight loss. So my first goal is to minimize your comorbid illness because of obesity. And that's where I think setting up the expectations is very important. You set up the expectations, and once patient achieves that expectation with the help of pharmacotherapy plus diet plus exercise, then we move forward to see how we can sustain that weight loss and keep them on. Any weight loss above that is bonus. I tell them you achieved your first target. Now anything you lose more than this is bonus. And then patients are motivated. So they work towards that extra effort they put in to lose that extra weight. So yeah, if you can get your BMI down to 23, that would be great. But most of us can't. But that's okay. At least your comorbid illnesses are under good control with the BMI that you have.
So just to give a perspective to our audience, say if a patient loses 5 kgs or 10 kgs, what is the difference in the blood pressure? Like how much does the blood pressure improve? By what points? How does the HbA1c improve? Or is there a difference in your fatty liver percentage? What do you want to add?
Yeah, this Dr. Kannan said right now, 5 to 10% weight loss, you'll start seeing changes in your blood pressure. Blood pressure tends to come down, the diastolic more than the systolic, and you may need to reduce your existing BP tablets actually at that point. And diabetes, depending on the duration of the diabetes and the degree of obesity that the patients have, we get different types of results. And as you start, losing weight for either naturally or through GLP-1, you can definitely expect low sugars if you're on the old generation diabetic medication, which needs to be cut down promptly. So definitely when you're going through weight loss, diabetes will improve, blood pressure will improve, your mental alertness will improve, the concentration will improve, the ease of moving, the ability to perform day-to-day activities, the sleep quality, the stress level. There are so many things which will improve with weight loss. And again, it's important to have a realistic expectation. There are several, celebrity kind of patients who come in with the expectation, I need to look better. That's the only purpose for the weight loss. That's not correct. If you have comorbid illnesses and then trying to get them under control will give you a risk reduction in the future for you. So just taking these medications or achieving weight loss just to achieve that size 0 that your friend or somebody is flaunting about is not the way to look at weight management.
So I think here the main message is that, the weight loss, whether it's with medicines or without medicine, it touches each and every aspect of your life. And I think that's something that all of us are chasing. There have been medicines in the past that were launched. So what is the history about these medicines and why is the buzz only currently now?
When you look at medications and treatment armamentarium from a physician point of view, what we had in our treatment armamentarium a few years ago, we had medicines that blocked the fat absorption from the gut. We had drugs which worked on the serotonin receptors in the brain. We had drugs that worked to suppress appetite by stimulating the catecholamine surge. All these drugs have been slowly, taken off the market because of side effects, not very efficacious, and patients had nuisance side effects with them. And the weight loss that we got with these medications were only a few kilograms, and they used to come back saying that the weight has come back even while I'm on the medications. And some of these drugs had safety concerns, and FDA had to remove them out of the market as well. As a physician managing obesity for the last 10 years, it's been a frustrating experience even for the physicians, because we didn't have a good solution for the patient's problem. Many a times when their BMI would cross 35 or 40, we would refer them to the surgeons. And gastric bypass, although a very well researched procedure and a very effective procedure, patients would hesitate. And that's a natural human tendency, and it's an irreversible procedure. So we didn't have much in our hands to manage obesity for quite a long time. GLP-1 analogs were launched as part of treatment of diabetes. And they were very effective drugs for diabetes. And we saw that they started helping patients lose weight. But they were not primarily approved for weight loss. And we used them as an adjunct for diabetes and weight loss. The weight loss was marginal, was there, but not all patients benefited. And now we are seeing newer molecules in the same GLP-1, and then we have the GLP-GIP mechanisms, which have tremendously helped us with patients achieving weight loss. So I think we are now seeing a shift in our armamentarium being more solidified with a lot more molecules that offer patients a lot more variety in their treatment options. And that, I think, is very satisfying when you're a physician who is managing obesity as part of chronic medical conditions.
Sure. Thank you for that. So, and I think at the outset, I would jump directly into the million-dollar question that do these medicines have to be taken lifelong? And then how does the picture look for somebody who is wanting to take these medicines?
Like diabetes, like hypertension, obesity is a permanent disorder. Many people fail to realize that. So the treatment what we are offering for diabetes, hypertension needs to be taken for lifelong in order for them to avoid the complications from diabetes and hypertension. And for obesity also, these medications work only for a week. The newer ones, semaglutide and tirzepatide, work only for a week. So once patients starts taking them, they start seeing the changes in their weight. And once they achieve the target weight, let it be 6 months or 1 year, it is recommended to be on the medication, because studies have clearly shown that there is a rebound weight gain in at least half of the patients when they stop the medication abruptly. But maintaining the good habits with respect to the diet and exercise during the time when the patients are taking this medicine, so that they accrue these good habits and then continue in the future, that is certainly a way we can reduce the dependence on this medication. Maybe we can reduce the dose of these medications. The maintenance dose can be 50% of what they require to achieve the target weight. These are the ways we are, yet to explore, because this is first year with GLP-1. We are seeing tremendous success rate with these weight loss stories in our patients. Almost 90% of the patients are able to lose weight and sustain it for the first time, what we are seeing here. So this is a great story for us. And yeah, in the coming year, we are planning to reduce the dependence on the medicine, provide the patients work with their dietitian as well as the physiotherapist to sustain those, good lifestyles that they have accrued.
Looks like the dose on which the patient can maintain his weight in the correct, in his goal range is probably what they will need to take for as many years as required. What is your view on this? And then how do we counsel patients about it?
Yeah, that's a very, that's a question that most people come and ask, is this for life? I tell them, probably not lifelong, but probably till a time when there is a set point change. So everybody's body's homeostasis is around a set point, and the set point has changed for various reasons. Because of genetic factors, because of environmental factors, the set point has changed, and the mind and the gut, there's a dyssynchrony, where in which the body will try to push you back to the older weight when you try to have efforts to lose weight. And that's why a lot of weight loss strategies fail, because you do the effort, you will lose weight, and then you stop the effort, whether it's a keto diet, whether it's another plan, then you will rebound. The weight will come back. That's because your set point is not changed. I tell patients that you have to be patient with this. You continue the medications till your body has made a set point change. And as Vinod rightly said, but also gives them the time to accrue good habits. You make sure you then know what is the right portion size for your weight. What is the exercise that you have to do to keep yourself fit and not keep your muscles toned. So those two are the time, and that time is variable between patient to patient. I mean, one patient it may be 1 year, one patient it may be 5 years. So it's very hard to say when I can stop. So I tell them that set point change will tell us I'll start lowering the dose and I don't see a rebound weight gain, then I know that you're closing in on the set point change. And that is a point when we can, probably think about coming down or stopping these medications. It's a very hard question, but I think we do approach it in that way. Though it's a chronic medical condition which probably will require, but then if patient has made a lot of changes to their behavior over a period of time, it gives us a chance to maybe, wean them off these drugs over a period of time.
Right. So I think we are coming to the most important part of this conversation, that obesity and GLP medicines is just one part of the story, and it is incomplete without appropriate lifestyle management, which includes diet, fitness, change in your habits. So I think this question is to both of you. How should patients, approach lifestyle change when they are on GLP medicines?
So mainly that kind of lifestyle change that we are looking at should start in childhood. Majority of these are genetic predominant diseases, diabetes, hypertension, and obesity. So the lifestyle changes should start much early in the childhood, because these diseases have a way of coming much early in the next generation. And even with the GLP-1s in play, we highly recommend diet and exercise as the base on which we build the efficacy of these medications. Definitely, these medicines are here to stay, and there are several people who can get benefit from this diabetes management. And once the weight is under control, their sugars tends to improve, their blood pressure tends to improve, their knee pain tends to be gone. There are even multiple new benefits like, the changes occurring in the liver because of the fatty liver. All these changes will get regressed, and several other benefits are being unlocked as we speak today. It's important to build a very good diet and exercise using the help of these medications, because many a times we see people try different types of diets and fail and then go back to the old diet. So that kind of permanent change when you're ready to make and you've tried and failed before, GLP-1s are the drugs which can help you achieve that result and then stick on to those good habits that you accrue.
And I think, when we give the advice of diet and exercise to patients in the past, the problem was compliance. They would not be able to sustain that diet for not more than a few months. And now we are seeing that these drugs actually help them be compliant to the diet. So, it is in a way that, the same prescription of diet and exercise which was not followed in the past is now getting followed because the molecule is helping you follow that diet. So, and I think that the hedonic or the emotional eating, which is there with many patients, is starting to get, blocked with these drugs. And that is, I think, making a big impact that, diet exercise is part and parcel of your therapy, only that now it is becoming more executed better because of the drugs. A small word here to improve protein intake and improve your muscle mass while you are on these drugs. These drugs don't differentiate fat mass or muscle mass or bone mass. All things come down when you lose weight, particularly when there's a rapid weight loss. So when there's a quick weight loss, you always have to be careful that you don't lose muscle mass as well. So protein intake under the supervision of a good dietitian and good exercise therapist to improve your muscle tone and core muscle strength is always part of any exercise or any obesity program. So I think that is very important when patients are on these drugs.
Right. So like always you have indicated, the role of a multidisciplinary team. So it is in the equation, it's not just the doctor and the patient, but it's the other care team members also who provide support. So would like to understand from you, what's the role of the dietitian, the fitness expert, or habit coach, so that, the molecule is definitely helping in better compliance. But what do the other actors have to play the role here?
So with the increasing popularity of these GLP-1s and a lot of social media coverage, everybody thinks that I can take this medicine on my own and then I can get the result. But it is not that easy. As Dr. Kannan said, there are some side effects that we need to watch out for. And even there are some side effects which may come in the future, like in the pharmacovigilance studies and the surveillance database. Those needs to be updated to the doctors who are treating these medications, and doctors are the one who are more up to date in their line of work. It's important to take these medications for any known or unknown side effects. Anything that new comes up in our patients, we need to be watchful for this, because they have relatively been they have been relatively new to the scenario. And in the past, we had drugs which caused dangerous side effects in the past. So we have to be really careful about these medications, and incorporating a multidisciplinary approach, a dietitian, a physiotherapist, and a habit coach will go a long way, because doctors, if you go to any clinic, cannot have the time to talk about diet for extended periods of time so as to give an impact in the patient's life. So, teaching them about what is the major food groups, what is the protein target, what is the fiber target. A dietitian can do a better job at this than a doctor. And a physiotherapist who is well trained, from the beginning in the techniques of, improving the body's tone, the muscle mass, applying the concepts of progressive overload. This is beyond, the scope of a doctor to discuss in clinical practice, especially when we have so many patients, when we deal with so many other conditions.
Right. Also, I think, patients relate to them better, as in, when they want to ask some questions, at times they feel, should I ask this to the doctor or no? And that is where I think this care team can really pitch in, and the long-term support that they can provide. I think that is something patients really look forward to.
Definitely. Wherever you see in our country, doctors are overworked, short-tempered, and patients usually they don't feel like, they can ask everything that they want to know, during that 10-15 minutes time. Yeah, a paramedic who is well-trained in these aspects can do better results for our patients. That is what we want to see in our society.
I think correctly mentioned, the training in that particular subject also matters. Yeah.
Yeah, I think the importance of a nurse who's kind of in touch with the patient on a weekly basis or or a fortnightly basis is very important when you're on these medications, just to make sure that they are doing well, they're keeping well. Some symptoms may be all right to watch and wait, and some symptoms may be a red flag which has to be reported back to the doctor. As you said, patients may be reluctant sometimes to report every single symptom, and when they tell it to the nurse and the nurse is well trained, they relay those symptoms to the doctor, and the doctor might offer them solutions and what to do for that. So I think it's important to have a good team, a doctor centered, but you have the nurse who's in touch with the patient, you have a dietitian who works around the diet, and a physiotherapist and exercise therapist who can gradually build up and different types of exercise based on the patient's comorbid illnesses as well. We're seeing patients with obesity with a lot of comorbid illness, whether it is severe osteoarthritis, whether it is sleep apnea, whether it is congestive heart failure, coronary artery disease. Then these people, everybody will require a different program and a different set of exercise therapy and schedule, which it's not one size fits all. And that's why I think it's important to individualize patient care. What works for a particular patient may not work for another patient. So a good team, continuous feedback with the patient is very important, rather than just you come consult, take your medications and come back in 3 months. That kind of an approach will not work in this chronic disease.
And with this kind of multidisciplinary team, we are seeing results as good as 95% of the patients achieving the weight loss that they desire. And few discontinuations are there, definitely because of the side effects from this class of medication. But the overall compliance is something that we have not seen in previous years of practice. All these 15-16 years of my practice, we didn't see this kind of results with any other class of medicines combined with multidisciplinary care.
I think that's wonderful, and that's why it's called as the next big revolution in weight management and obesity. So one question that patients have in mind is, am I eligible for these medicines? So how do we know who is the correct patient or a candidate for these medicines?
Well, we can probably flip the question around and ask the question, who should not be taking these drugs? And I think there are certain side effects or risk factors where these drugs would not probably be advisable. And they would include if there's a hereditary family history of thyroid cancer. We call this medullary thyroid cancer. Although there is no evidence in humans, there is evidence from rodents that these drugs can cause this rare form of medullary thyroid cancer. So if there's a family history of thyroid cancer, you would probably have to check with the physician, are you still eligible or not? People who have had pancreatitis or inflammation of the pancreas, again, is a concern that we would not immediately start these drugs. People who have had gallbladder inflammation, gallbladder stones, which has not yet been operated, again, it's a red flag that we would want to wait and sort that issue out before you consider these drugs. People who have had inflammatory bowel disease, so people who have already issues with their gut, again, they're not contraindicated, but I think we would be watchful and we probably not use them right now. People, again, planning pregnancy. Data from children still not yet in the market, but I think they will soon get approved in the ages above 11. But I think we have to be careful when you're using it in the pediatric age group. Again, in patients who have advanced eye disease because of diabetes, again, I'm a little cautious before I think using these drugs. Now, barring these, and I think most patients with obesity who don't have a lot of comorbid illnesses, BMI is about 27 or about 30 with comorbid illnesses or 35 without any comorbid illnesses. I think one should offer them this therapy. Whether that would be the first line of management or comes down the line depends on the particular patient and their ability to stick with the plan. But I think that is how we approach this. This is now offered as regularly as how I would offer a anti-diabetes medications or an hypertensive medication. I would offer them the same way, that there is medications available for you that you can take. And we also look at what is the amount of weight they have to lose. If the amount of weight loss is, say, about 8 to 10 kilograms, then they have more options. They have tablets, they have injections. But if the weight loss is, say, in excess of 20 kilograms, then I give them the option that it works more better for them. So you also tailor your drug choices based on what is the target weight loss that they want to achieve. So that's how we approach this when we see patients in the clinic.
So when we say comorbid illnesses, what all do we mean by that?
A host of them. Many of them related directly or indirectly to obesity. So typically we would see diabetes, pre-diabetes conditions, hypertension, fatty liver disease, which is a very, very common condition, which is again not very appreciated well, but it's kind of the root cause of many of the chronic health conditions. PCOD in women, but again becomes a problem that causes is an effect of the weight gain itself. Vinod said osteoarthritis of the knee is again a common problem. Sleep apnea, obstructive sleep apnea is a very important comorbid illness. Some people have anxiety, depression because of their weight as well, and that again gets much better. You have to be a little careful here when you are teasing out an underlying psychology or a psychiatric condition which is because of the weight, vis-a-vis a primary psychiatric condition which has made the weight worse. So that is a little subtle distinction between the two, and one has to get appropriate reference from the psychiatrist when you're managing some of these patients, because if the mental health is not being taken care of, these drugs may not work very well. So that's important to know that comorbid illness as well.
What would you like to add, Dr. Vinod, to this?
Anybody with weight issues who've been trying to lose weight and they see that as a problem, because majority of the time patients don't see weight as a problem in India. So if they've been trying to lose weight for the gains that they see with respect to their diabetes management, hypertension management, or they have a family history of heart disease they're worried about, they're approaching that same age what their parent had, all these patients can definitely use these medications, provided we need to screen them for certain rare conditions, which are very rare. In fact, medullary thyroid carcinoma, Mantoux syndrome, they are very rare in Indians. And barring that, majority of the patients can harness the benefits of these medicines. BMI 27 and above with one obesity-related condition, or BMI above 30 without any health condition, many people can take the benefit and then, get the long-term benefits. The long-term benefits include they can postpone the diabetes, they can have a better control of the diabetes, they have it, they can even, some of them, with big obesity, if they lose a lot of weight, they can get rid of the daily injectables like insulin and reducing the dependence on several of the medications. If they are in your early years of diabetes, within 5 to 10 years, if you use a lot of weight, like 10 to 15%, they can achieve diabetes remission. These are all the benefits that all the patients who are obese and, when you use GLP, these are the benefits that they can harness. And simultaneously, we have evidence also from 5-year-old studies now, they've been there for 5 years, that the cardiac events also come down. There is 33% reduction in the risk of heart diseases and the kidney protection. So these are not just obesity drugs, and these are obesity drugs which has multiple benefits. One is diabetes, hypertension, prevention of heart disease, kidney disease, and improve the overall quality of life as well. And there are some other benefits which are being explored, like in alcohol cessation and usage in obsessive compulsive behaviors, and even in gambling addiction. These medicines are proven to be useful, but not the sole indication right now. So we need to look at the indications that are approved right now: BMI 27 and above with a obesity related condition, or BMI above 30 without any obesity related, without any other condition. And type 2 diabetics definitely can use irrespective of the BMI.
So we were speaking about addictions. How do these medicines help in controlling cravings?
Very good question, because cravings we all have faced. Every one of us is going through this journey, and we know what a craving is, what is the real hunger. Yes, these two are two different, biological signals which are controlled by two different areas in the brain: constitutional eating as well as the hedonic eating. In patients who are taking this GLP-1s, it works on both the centers, and very commonly people tell this food noise is gone. The moment they take it, as soon as within the first day itself, some people experience this. The constant, thinking about the food in the background, what to eat in the next meal and how much to eat and what to plan in the next week for the next big vacation or with the team party. These are all the things going on in the back of everybody's mind. So the cravings will stop on the day when you start this medicine for several of the patients on GLP-1 drugs. And that helps them achieve the calorie deficit, which is the cornerstone for management of the obesity. So it makes it easy for patients to achieve the weight loss. And one more thing I would like to say about this GLP-1 drugs is, whenever somebody is trying to reduce their calories by achieving a deficit, body increases these cravings naturally. And then they resort to a cheat day. One day they go and then eat everything and then gain back that weight. So we don't see that phenomenon with this medicine, mainly because these medicines create a craving control, as well as it corrects the metabolic defect which led to this problem. So partly not just because of the hunger suppression, we have other medicines, previously which can create a calorie deficit, but we didn't see this degree of weight loss. It prevents the body from slowing down the mechanism, the metabolism, when they're trying to achieve the calorie deficit. So it works in multiple ways, not just by reducing the appetite or craving control. It also, the GIP part, there are dual agents right now available: tirzepatide, GLP plus GIP. It changes the way body stores the fat inside your body. So even, there are patients, yes, we highly recommend doing strength training, protein intake and fiber intake and water intake. That all needs to be increased when you're on this medicine. But most importantly, even some people cannot do that, still they lose the weight. So that is, there are some mechanisms that we understand right now. There are much more behind this medication.
Would you want to add something?
I think it's covered beautifully. So I think the three important mechanisms, to sum up how these drugs work is: one is it fixes your, gut-brain synchrony. The gut has to tell the brain how much to eat, and the brain has to signal the gut in terms of, are you hungry or not? So the gut-brain synchrony is reset with these drugs. Your gastric motility is slowed down, so you can't eat a large portion at one go. You have to control your portion size. And the third one is the insulin kinetics. The kinetics of insulin is much better. The insulin resistance is much lower. So your disposition of energy into fat versus heat is again switched. So you take the calorie, but that calorie is now expended as heat rather than stored as fat. So all these mechanisms, and of course, a lot more mechanisms which we don't know of, are working behind these weight loss. But the primary, the gut-brain synchrony, insulin kinetics, and your gastric motility and slowing down of the gut is primarily how these drugs help in cutting down the craving, shuts down the reward center of eating. And that's important. That's why a lot of the offshoot effects on addiction disorders, alcohol, gambling, and things that have come up is because the reward centers have cut down when you're on these drugs. So this is and that is why we are able to see very effective weight loss with these medications.
So I think that feeling of satiety, I think that also is somewhere strengthened, and then that helps the patient control the cravings.
You have to be careful. That body is again a beautiful biological living thing, and it will find its way to fight these drugs back. So that is also something that one has to be cognizant. It's not always that you take these drugs and you will lose weight. There are people who've taken these drugs. They say that my appetite came down in the first few weeks, and then now I'm taking these drugs, but my appetite is now coming back. So you can see that there are pathways that the body will take to offset the effects of these drugs. And that is why I think being in touch with your physician, working with the team really helps, rather than trying to just depend on one molecule and say, I'll take this and I'll lose weight. Might happen in a majority of patients, but there are patients who will not be able to achieve the weight loss because there are mechanisms and pathways where the body will kind of find its escape route and you will not be able to lose weight.
But again, there is no need to be discouraged about it, because last 5 to 10 years, there has been increased research and newer GLP-1s with triple drug actions and non-GLP-1s which give the same kind of results. They are all in the phase 3 trials now. And in the next 5 to 10 years, we're going to see better medications. Once in a month, GLP-1 is also in the works. All these things will come, but there is no need to lose hope for the patients who are trying to lose weight and say it is a problem. And definitely, this is a good opportunity to work with your multidisciplinary team, especially the doctor-driven programs, where multidisciplinary team is educated. They are trained about what to look for and what to do, what happens. These are the things. These are the ways. It's an excellent opportunity for people to lose the weight using these medications. And we are on the constant lookout for any, future problems these class of drugs poses. And as Dr. Kannan said, there are few non-responders. So, your body is different than the other. So everybody is unique. So people who are younger in age, they tend to lose much faster, right? As well as with the lowest dose of drugs. Even with 2.5 liters appetite, there are patients who lost 10 to 15% of their body weight. And, there are some patients, long-standing obesity, diabetes with complications. They may not respond, even with 10 or 15 mg of tirzepatide or 2.4 mg of semaglutide. So every case is unique. We need to look at the patient's history and then see the results and slowly titrate the dose up in order to avoid the GI side effects. Most commonly, these drugs cause, loose motions, vomiting, burping, terrible burping in the first 1 or 2 weeks, and constipation in the long run. These are all the things we need to educate our patients. So if these come, you need to reach out. These are the things you need to do. So that safety netting needs to be there. And most patients, though they develop these side effects in the first 1 or 2 weeks, or, when they're increasing the dose to the next level, they tend to tolerate them well. Almost 95% of them continue on these medications, and except for few non-responders, majority of the patients tend to lose weight.
And I think this is the most important message to the community at large. So now coming next to fun, quick, rapid fire questions. First to you, Dr. Vinod. Scale or blood reports, what matters more?
So yeah, both are important. I would say the tape measures more. Tape is an even more important tool. So measure your central obesity. If it is more, definitely you need to work on both.
So BMI or body composition analysis?
Body composition analysis is a better tool than BMI. BMI doesn't cover everything.
Sure. So maybe we'll also speak about body composition analysis in detail. Lifestyle or medication, what's more important?
Lifestyle is more important from the childhood. And when your lifestyle is not getting the results, definitely take the help of medication.
One habit that gives the biggest return.
Good habits. That will give you the best returns.
But if you have to pick just one?
So among that, diet, I would say. A clean diet from the beginning will give you the better results than exercise or even anything else.
Biggest weight loss myth you want to bust?
Yeah, weight loss is not temporary. You need to sustain it to get the benefits. That is the main thing. Many people tend to look at it as a short-term target once they reach their target weight, and then they can go haywire with their old habits. But that needs to be sustained with the efforts that you have, put to achieve that result.
One thing people should stop doing today.
Smoking.
Coming to the next questions for you, Dr. Kannan. BMI, useful or misleading?
I think for the time being, it is useful. I think our cutoffs of medications are also based on BMI targets. I think Dr. Vinod mentioned that as well. So I think it is useful. We need more tools to specifically find out more, people who are appearing thin on the BMI, but they still are obese. I think BMI is still useful right now.
Sure. GLP-1 trend or long-term treatment?
I think they are long-term treatment. They began as long-term treatment for diabetes. So I think they will be a long-term treatment for obesity as well.
Hormones or calories, what drives obesity more?
I think a mix of both. I think that it's not just calorie in, calorie out. There's a lot of changes, particularly insulin pathways, which affect these mechanisms. So I think it's both.
Sure. Is GLP-1 for everyone?
The strict answer is no. But I think if you are someone who who has done the right things and still not able to lose weight, I think it is definitely for you.
Biggest weight loss myth you want to bust?
People look at weight loss as a quick short time fix. It is not. It's not a 100-meter race. It's a marathon. So we start slow but sustain and go for a long period.
One thing people should stop doing today.
Not have their last meal of the day after sunset.
All right. So let's speak about body composition analysis and its role in understanding the overall physiology of the person and then recommending the correct course of treatment.
Traditionally, we looked at weight as the measure of somebody's own health. If weight is increasing, naturally everybody gets worried. But even with the same weight, two persons have two different types of body fat percentage and muscle percentage. So now we have these tools, simple smart scales which are come. People can monitor this progress, whatever, whether they are trying to do regularity with their exercise, whether doing dieting, or whether they're taking GLP-1s. It's important to monitor that. Not really everybody needs to get a DEXA scan which contains low dose X-rays, but the smart scales using BIE electrical impedance technique, they can get to know a rough estimate of their body fat percentage, and the muscle mass. So they should aim to keep that body fat percentage below 20% or 15% if you have different health conditions, and try to gain as much muscle as possible. Walking, is a popular exercise, but that alone will not increase the muscle mass across the body. It's important for everybody starting from childhood to, elderly age, to start some kind of strength training. Training all the muscle. Human is made up of flesh. So you need to train the muscle from the beginning and then try to retain as much as possible, because muscle mass itself has been shown to be the single most important predictor of cardiovascular morbidity. So important to maintain a good muscle mass. And as we age, muscle mass tends to come down, especially with the low protein intake that in India we see it's very rampant. So people should start increasing, in order to improve muscle mass, there are three elements. You need to eat high protein diet, take sufficient rest, and sufficient stimulation as well in form of continuous exercise with progressive overload.
So is it cardio alone or even strength training?
A mix of both. Cardio at least 3 to 4 days a week, and then 3 to 4 days a week strength training will give the best results.
So usually, people prefer going to gyms. So while that is also required, what is the medical take on that? How do we approach strength training?
I think it's important for us to assess patients with obesity carefully in terms of their risk of cardiovascular disease. People may feel fine, but that doesn't mean that they are healthy and cardiovascularly fit. Particularly if somebody's got very high levels of LDL cholesterol, there's a family history of coronary artery disease. I think one has to be careful to assess and screen them for any kind of significant medical conditions that they might have before hitting the any kind of exercise therapy that they can do. So I think before they go to any nearby gym or any exercise center that they do, I think it's sensible to consult their physician, ensure that they are medically fit to do that. And again, there's a lot of fad about having protein powder, having things that they are recommended, taking hormone injections, and that's something that's also quite a bit of a buzz in terms of testosterone, growth hormone, HCG injections, which are in fact shockingly available in a lot of these without medical supervision. These are not safe. They tend to increase your hemoglobin levels. They tend to increase your viscosity of the blood, cause an increased risk of heart disease. So I would strongly recommend that people don't take hormone-related injections to improve muscle mass, because that can have very dangerous side effects in their overall health.
Yeah, so I think the main important message here is that you can do whichever exercise you like or prefer, whether it's yoga, strength training, cardio, but that should always be discussed with your doctor whether you're not at risk of something, and it should always be under medical supervision. So I think that's the main bottom line here. So as busy professionals, are there any messages that you would want to give those who are just tackling with their day-to-day work, plus there is a lot of work pressure, stress in different forms? So, what is your message to such patients?
Yeah, definitely. As you've pointed out, the, traffic conditions are bad. People need to spend more time in the traffic to commute to work. And they have very little time, to be fair, to spend on their own health and go through a structured weight loss program or even exercise or prepare the diet in that perfect manner. Definitely nobody can be perfect. There are some problems with this in the society that we cannot spend more on. And it's important that people start seeing obesity as a problem, because obesity is commonly seen as, healthy thing. If a child is obese, mother will be very happy, thinking that the child is going to be healthy. That used to be the case 50 years back, but now because of the abundance of food and increasing obesity, diabetes, it's important to see that as a problem and then start working up. And just like, we have medicines for diabetes and hypertension, no matter how much we do best with our lifestyle changes, we cannot get them under control. Obesity also has medications now. People should warm up to the idea so that the cardiovascular diseases, which is the leading cause of mortality in our country, comes down in the future.
Sure. What would you like to add?
The crux is to be attentive to what you eat, right? I mean, you have to pay attention to what you're eating, and unfortunately, we are carried away with the flow of the day, the flow of the crowd, the flow of the people around us, that we just don't pay attention. So I think if we can all pay attention to what we eat, how much we eat, when we eat, makes a big difference to our overall health. And I think that's a message for everybody, and not just people who are tackling obesity, but I think for everybody, just be attentive to what you're eating. So a lot of times I see people having a smartphone on one hand and eating on the other hand. That's the wrong thing to do. I mean, you're not attentive to what you're eating. So you will be eating as long as the program is going on the phone. You don't even know how much calories you've consumed. So it's extremely important that you're attentive to what you eat. Pay attention to eating, and that is the first step to know that are you eating right? Are you eating healthy? Are you eating balanced? And are you eating on the correct time? So if you can pay attention to these metrics, simple metrics, but it is difficult to sustain in when you are busy. But if you can sustain these, this goes a long way in helping you lose weight.
So I think in general, the awareness and being mindful about what condition I'm facing, who I am, I think that we will give the correct perspective to the person. And just as much, time and effort we put on managing our finances, I think even 50% of that, if we put in managing our health, I think a lot of these health conditions will be addressed.
Yeah, excellent point. I would like to add that, healthcare is getting expensive. If you land up in a complication in a, private hospital, any hospital, in any city, it is going to definitely burn a big hole in your pocket. It's important that you focus on prevention aspect, preventing the heart diseases, preventing the kidney diseases. Good management of diabetes and obesity and hypertension will lead to better dividends in our society.
So we had a great discussion today. If you are somebody tackling with weight issues and is considering GLP-1 medicines, please reach out to a doctor for correct scientific approach for tackling your condition. This was a great experience for us doing this podcast. I hope the audience has also enjoyed it. Thank you so much for joining us today.